Hello and welcome to the April episode of the IJA Authors Podcast. This is me, Gayatri, your host. I promise that I have some real excitement in store for you all today. And we also have a celebrity in our midst in the episode today. Friends, today's episode, like I said, is very special because like always, we have 3 articles, but this time we have 4 authors and one of them, like I mentioned, is a celebrity in the anesthesia academic circles. So let me not keep you all in a state of suspense anymore and introduce our first and very special guest to join us today. He's a man who gave us www.capnogram.com, otherwise known as Capno Man. I'm sure anyone who's ever presented any lecture or talk related to capnography has used the valuable resources and wonderful graphics on this website. He's a teacher par excellence, a brilliant researcher, the author of popular and numerous textbooks in anesthesia, someone who has more than 40 years of experience in obstetric anesthesia and who's currently the chief of the University of Maryland Medical Center, professor of anesthesiology, University of Maryland School of Medicine, Dr. Bhavani Shankar Kodali. Dr. Bhavani Shankar Kodali, welcome to the podcast and thank you so much for joining us today.
Sure, thank you. It's always a pleasure.
So I was really excited to see your article, which was the relationship between maternal, arterial and fetal cord carbon dioxide tension and neonatal outcome in critically ill pregnant women at delivery. I must confess, I was happy not only to read the article, but also I knew that I'd get a chance to interview you this time for the podcast.
Thank you. Thank you so much. And also thank you for Dr. Rakesh Garg and the editorial team for reviewing the paper and asking me, some critical questions and made some changes on it actually.
Okay, so Dr. Kodali, your group has studied A, the relationship between maternal arterial pressure of carbon dioxide and cord blood carbon dioxide tension, and B, you have looked at the relationship of maternal high carbon dioxide tension with Apgar scores as a marker of neonatal outcomes. Can you share with us the background behind looking for a relationship between these parameters? Were there any prior experience with good or bad outcomes in babies born to critically ill mothers?
Now, actually, you all must be familiar with what happened 2-3 years ago when we had a big load of pregnant women with COVID. And when they were put on mechanically ventilated and ventilation, several questions actually that came up at that time, because before that we were all putting patients on ventilator, but we never thought in a way we thought during these 3 years. Now, we didn't know, what are the precautions actually you must take while intubating these critically ill pregnant women. And ADSNet protocol, which is widely used in all intensive care units, is it validated in pregnant women or not was a question. Now, how feasible to prone a pregnant woman on ventilator or ECMO? Then, does delivery impact maternal ventilation? Then, what is the permissible hypercarbia you can allow in a pregnant woman with a baby inside? Then, is there any relationship between the maternal blood gases and the fetal blood gas? So these are all the questions that came up during that time. And that's the time we actually we looked into the literature. And what is fascinating in the literature is, number one, it is very scanty. There are very, very few papers. Number two, an important thing is people misrepresent some of the studies. One paper writes something and all others do not read the original paper where it originated, when it originated, but they just keep cycling that reference. And then we found out that there are no studies that are done on this subject since 1970, actually. So all for 50 years, we have been just, following what is written in the literature based on certain papers, but no one actually really looked. How did those studies were done? Where were they done? In what group of patients, they were done. So that is why we took this opportunity during this COVID time to answer some of the questions, actually. And we published a series of papers, actually. And the last one in that, probably I should say second last, The second last one is thus with the maternal, what is the permissible hypercarbia you allow in a pregnant patient and a critically ill woman? That is what is most important.
So your last paper has an answer to that question?
So to answer that question, actually, first of all, as some of the reviewers pointed out, it is a very difficult study to do, because to get pregnant women on a, you don't know when they will arrive, which hospital they arrive, and how they are managed. Very, very difficult. So to do a multi-center trial or a large studies is extremely difficult. That is number one. Number two is there are so many compounding factors in a pregnant woman who is critically ill. There's the infection that affects. Then there is, drugs we use. You cannot put a pregnant woman on a ventilator without using ancillary drugs. Maybe propofol, maybe fentanyl, maybe midazolam, whatever it may be. You have to use it. Then you have to maintain the blood pressures by giving some vasopressors if there is a requirement. So to isolate one single factor to say that this is the cause of the final thing is impossible. I don't think you'll ever can do that in a pregnant woman. But what is fascinating to understand is you cannot simply interpolate the results done in a healthy pregnant woman to a woman who is critically ill and make your decision of either delivery or adjusting the ventilator.
Yes, absolutely. So I was just reading that, earlier studies have shown that maternal acidosis is associated with poor neonatal outcomes. And to circumvent this, your group had given bicarbonate infusion to these women. And like you said, there are so many factors that really cannot be controlled in a pregnant woman, leave alone a critically ill pregnant woman.
Correct.
Yeah. So could you just summarize to our listeners what the results of your study were?
So first of all, you raised one point about the bicarb. Now, pregnant women, particularly if there is an infection in the COVID times, we found that there is a gross metabolic acidosis. I don't know how many of you have looked at the blood gases in those women. They're actually gross metabolic acidosis. When there is a metabolic acidosis in the mother, we know that the baby has metabolic acidosis. There's absolutely no doubt. They're parallel, by 0.1 less actually in the baby. Now, we all know that a pH of less than 7.2 in a baby is not good. That is why the obstetricians will do a scalp, and if the pH is less than 7.2, they go for delivery. So what we have done is we actually put these patients on bicarb infusion. We corrected the maternal pH to near normal. Whether it is we allow permissible hypercarbia or not, that is a different question, but we made the pH normal. In fact, I correct pH for all pregnant women whenever I find them abnormal. In fact, my obstetricians are so well trained by me now, is, by what I do or my philosophy of thinking, they always try to treat the metabolic acidosis even in severe preeclampsia. So that is about the bicarb. Now, when we delivered this, so because we had fair number of deliveries on mechanical ventilation, I should say 25, the sample size needed was actually only 24. And this 24 was an indirect interpolation of a normal population, to a critical. So actually we needed only 8 or 10. But because it is a critically ill multifactorial, it was 24. So we had about 25 at least in this. So these babies were born on ventilator or on ECMO. So we had the maternal blood gases, we have the fetal blood gases, and we had the neonatal outcome, at least the immediate neonatal outcome. What we found was that when the PaCO2 is over 45, the Apgar scores at 5 minutes was actually less than 5. So that means these babies are born with a low Apgar score. Contrary to what was before in the literature. It's very fascinating how the study was done in the normal, how this study was done, that hypercarbia is good for the babies, was in a healthy pregnant woman, which you cannot do these studies now. 45 women divided into 3 groups. One group had saddle block, another group had ventilation and hypercarbia with by closing the circle absorber. Yes, absolutely. And then during methoxyflurane, Another group had, has hyperventilation. That means you reduce the PaCO2. And what they found was when the PaCO2 was close to 50, the Apgar scores were better. And why they were better in a healthy pregnant woman? The reason is PaCO2 increases the cardiac output. So probably there was a better perfusion of the babies. Number two, it decreases the uterine contraction. So there's a better uteroplacental blood flow. And number three is a shift of the oxygen dissociation curve to the right because of hypercarbia. And that probably gives more oxygen to the babies. So the babies did well. However, and then the maternal to fetal difference was only 1 millimeter in that group of patients, in healthy patients. But
the maternal to fetal carbon dioxide tension?
Yes, was only 1 millimeter. Suppose if the maternal PaCO2 was 57, the fetal PaCO2 was 58. So they just 1 millimeter. But in pregnant women who are critically ill, this difference is almost 17 millimeters. So it is.
Why do you think there is a difference like that? Why is it that in a critically ill woman, hypercarbia is causing bad outcome, like lower Apgar scores?
That is probably because of, number one, first of all, here the hypercarbia is chronic. It is not like a 10-minute study that was done in 1970 and you say that everything's fine. This is over the days, the PaCO2 is high. Number two, there is an effect of infection on the baby, I suppose. Then there is, of course, concomitant factors of the drugs. But when we looked at our results, all the parameters in the baby were within the normal range, except the PaCO2. So in one way, we can say that could be the effect of PaCO2. On the other hand, where the maternal PaCO2 was in the lower range, say in 30s and 40s, the babies had better Apgar scores despite the sedation, despite the infection, etc. So there is an indirect, probably PaCO2 did affect because of the chronicity. But however, as I said, it is very, very difficult to piecemeal. That is why when this discussion came, with the critical reviewers, one point is indisputable here, that the babies delivered around 50 PaCO2 will have babies with a low Apgar score, whatever may be the reason, and they need neonatal support. That means your NICU team must be ready to resuscitate these babies. That at least no one can dispute. Whether we can have a long discussion whether PaCO2 was the cause or something else is the cause, but we cannot dispute that these babies are really abnormal, and therefore we have to take precautions.
So I was reading the article and I was really interested because it was like a Pandora's box of questions opening up, right? So I was just interested to know that during the period of your study, was there any part of the result of the study that kind of piqued your interest and you think that could have a translational value in your clinical practice?
Absolutely. During the course of all this happening, we all had a debate. Should we ever wait up to 34 weeks to deliver or deliver the babies earlier? So we were actually delivering the babies sometimes at 32 weeks if things are not in good shape. So that is one important issue. The conventional wisdom is always the obstetric indication, right? That means when there's a good obstetric indication, you deliver the baby on a patient on a mechanical ventilation or an ECMO. Yes. That probably has changed in our thinking. What we have to do is we have to put everything together. What is our staffing? Because 50% of the patients who went on ECMO had a stat cesarean section in the ICU. And many patients in the ICU had to have a stat cesarean section because of persistent bradycardia. So the question is, do you want to wait until something really goes wrong in the ICU and then do a stat? Or if your facilities are good, and if you have the capacity to deal with these babies at a slightly, say, 30 weeks or 32 weeks, maybe you can deliver these babies little early, take care of the babies, then the mother can tolerate little more hypoxia, doesn't matter. The mother can tolerate a permissible hypercarbia. In fact, we had a patient after the delivery, the maternal PaCO2 went to 95 because of tension pneumothorax. So that could not have that if the baby was inside, the baby couldn't have tolerated that kind of metabolic acidosis or respiratory acidosis. So the point of all this is we have to put together many things when you start, when you think of when to go on ECMO. Is it worth going on ECMO or deliver the baby and have a permissible hypercarbia for the mother? So it is not a very simple thing saying that, well, babies can tolerate 50, but those studies were done in healthy pregnant. So it's a very interesting thing now to think in a different way. And one last thing which I want to say is, it's very fascinating if someone could study what happens to these babies who are born with abnormal blood gases down the road, say in 5 years or 10 years. We have all the data at the time of delivery, but we don't know where these babies went because ours is a big referral center. So if someone can track these babies and say, look, I think these babies, despite whatever happened during the delivery, or despite whatever happened to a pregnant woman on mechanical ventilation, these babies are doing fine. Although some of my colleagues feel that they may not be doing well. That is their thought, but we have no evidence on it.
Yeah. So I see that your study has paved way for future research, one on maternal ventilatory parameters, and then maybe even on future outcomes in children born to mothers who are critically ill.
Yes, absolutely.
Yes. And you were saying you were going to Boston for talks about your
Yes, actually, I'm going to Brigham and Women's Hospital on Tuesday to give a grand rounds there, and the title is pulmonary ventilation in critically ill pregnant women, answering the questions that has not been answered.
That's nice, lovely.
So this is the title where I'll be dealing with five or six aspects like, what is ADMET's protocol? Is it validated in pregnancy? Can the pregnant patient tolerate prone position? What are the ECMO parameters we need to adjust to maternal physiology? What can we predict fetal blood gases from maternal blood gases? What is the permissible hypercarbia and where did this 50 originated from? And
all right, okay.
So these are the things I'll be discussing there.
So, Dr. Kodali, we have a very important person who's going to join us now, Dr. Rakesh Garg, our editor-in-chief. He's been listening in on our question and answer session. He wants to ask you a question.
Sure.
No, I thought I should not miss thanking Dr. Kodali for his contribution. And I'm sure we have always, during our postgraduate time, have visited your website and looked for various capnography. I was just curious, and there are many youngsters from across the globe who are looking for some of the basic tools and how to spread those knowledge. What makes you passionate about capnography? I mean, your website is totally dedicated to capnography. So I'm looking for people to talk about anesthesia, regional anesthesia, but you have picked up a very important aspect. So what fascinates you in capnogram?
Well, if you have time, I can just give you a little story how it started. So I was in Barbados in 1984. And in 1984, one paper got published in Anaesthesia, the journal that comes from UK, saying that for the vein anesthetic circuits, the flow rates required was 100 ml per kilo per minute to maintain the normocarbia of pregnancy, which is 32. But in Barbados at the time, we were using the vein anesthetic circuits. And we were giving only, we were giving 100 ml and they wanted 120 in that paper. With 100 ml, our blood gases were normal. So then I looked at, they never measured the arterial CO2 in their study. They measured the end-tidal and assumed that the arterial CO2 was higher. So that is the time I actually got some interest in the capnography. It was just coming. And then I studied, actually we published 4 or 5 papers at the time saying that the end-tidal reflects arterial CO2 in pregnant women. That is why they had a little bit of a higher flow. So when I came to US in 1993, I found that many people in US were not aware about what is the real value of capnography. They put an endotracheal tube, they see the CO2 is a great. But no one actually really studied what is the relationship between the CO2 waveform and the cardiac output, and about the modes of the ventilation, etc. So that is the idea I got actually from the Brigham Women's Hospital, then started this website. And then I learned some of those drawing figures on using Macromedia fireworks, and then drew the figures. That is how the website was actually put forth in 2002. 2000. It is almost completed 25 years.
Absolutely. If I put it this way, am I exaggerating that capno is mandatory for all the patients under anesthesia? If you talk about GA, general anesthesia or regional anesthesia, am I exaggerating this one, or you will agree with me, sir?
No, I agree completely with you. It is a standard. It is a standard of care in many countries. And I have been trying to get our ISA to actually make it a standard. See, they tell me that if you make it a standard, because we cannot follow it. My point is this. Unless the society says that it is mandatory and it is next 4 to 5 years, everyone is required, because we understand it takes time to get capnographs and understand capnography, etc. Next 4 to 5 years, we have to make it mandatory so that all the government organizations, the private organizations have 5 years of time to put together their plan and implement it as a standard. This is a classic example in England. In England, ICU use of capnography in the ICU was only 20% once upon a time. Now it is 100% because they came up with the national airway study, etc. And they found out that capnography is critical, but they gave some time to them, saying that next 3 to 4 years, we will make it mandatory, and now it is mandatory. So unless you come up with that kind of philosophy, it's very difficult.
I think I can assure you that Indian Society of Anesthesiologists is coming with good guidelines now. We have 4 guidelines from Indian Society of Anesthesiologists, and I think they are world renowned and they are bringing a good impact. And ISA is working great on this. And likely, if you see, we will be listening to the other authors and researchers in today's podcast. I think a good research is coming from India also. I think India is a global star, and I'm sure that we will bring all the guidelines, all the standards as per the international norms, and India will be on the top. I'm not exaggerating probably. I think India will be leading into the academics and research very soon in near future, because we have a good team of researchers, academicians, and I'm sure people like you will be mentoring us in a right direction. Thank you so much.
No, thank you so much, sir. Thank you so much.
Dr. Kodali, I remember I'd met you for a leadership summit a couple of years before COVID, and you had a very interesting story to share when you moved from Barbados after you had published about 5 to 6 papers on capnogram, and then you moved to the US. Some of your senior residents actually asked you whether you even know how to intubate a patient. So it was, I was very inspired that, even people like you also get criticized by or underestimated by people. So it was a lovely interaction with you then, and it's been the same after, I think, now 5 years. Thank you so much for joining us at the podcast. It was a really pleasure to have you here on the podcast.
Sure. Thank you so much.
The second article we're discussing today is Prevalence and Predictors of Preoperative Cardiac Autonomic Dysfunction Among Elective Neurosurgical Patients, a Prospective Observational Study. And to throw light on their work, we have not one, but 2 of the authors of the article joining us today. We have Dr. Sangeeta RP, Associate Professor, Neuroanesthesia and Neurocritical Care, NIMHANS, Bangalore, who's the first author of this article. And I welcome Dr. Sri Ganesh Kamath, Professor and Head of the Department of Neuroanesthesia and Neurocritical Care, NIMHANS, Bangalore, who has been extremely kind in accepting our invitation to join the podcast today. Dr. Sangeeta and Dr. Kamath, welcome to the podcast.
Thank you, Dr. Gayatri, for having us, and greetings to all the listeners.
So, Dr. Kamath, my first question is to you. Why did you decide to do this study? Or if I may put it this way, Could you share with us a little about the background behind choosing this topic?
Yeah, so we all know that autonomic nervous system is very crucial to maintain the systemic homeostasis in patients, especially in the perioperative period. But the burden of autonomic nervous system disturbances in neurosurgical population is currently not known. But however, we believe that this autonomic dysfunction is likely to be more in neurosurgical patients because of the influence of the neurosurgical pathologies. Second, we were also curious to know if there are any predictive factors for cardiac autonomic dysfunction or CAD in our population. And because this was important to know whether there are any consequences of preoperative CAD on in the perioperative period. This would help us to prepare well and better for the anesthesia and surgery in these patients. And that's why we thought this study is required.
All right. Okay. Sangeeta, Dr. Sangeeta, I believe such a study has not been done in this group of patients, that is in the neurosurgical population. Were the results of your study comparable to similar such studies done in non-neurosurgical patients?
Thank you for this question. You've rightly mentioned that there are no precedent studies on cardiac autonomic dysfunction, that is CAD, among neurosurgical population. We conducted this study to bridge this knowledge gap. Previous studies have reported a preoperative cardiac autonomic dysfunction prevalence rate of 56% among 50 patients who underwent abdominal surgeries, around 68% of 80 patients who underwent both major abdominal as well as cardiac surgeries. There are two other previous studies that have used the same device as ours. Of the two, one study diagnosed cardiac autonomic dysfunction in 62% of parturients undergoing cesarean section surgeries, and the other reported a 65% CAD incidence among cardiac surgical patients. This was based on an ANS index above 13.5. So compared to these studies, our study showed a higher prevalence rate of CAD, which was around 79%.
79%.
The possible reason for this could be that diseases affecting the central nervous system affect the autonomic nervous system as well, especially those directly affecting the anatomical location of the central autonomic neuronal circuits. Examples being lesions involving the hypothalamus, insular areas, and the brainstem.
All right. Okay. So I'm going to now deviate a little bit out of the study to just ask you, I understand you received a grant for the conduct of the study. So did you meet with any hurdles on this path? And do you have any tip or a word of advice to others who are trying to apply for such grants?
Yes, I received a research grant from the Vision Group in Science and Technology, Government of Karnataka, to conduct this study. Hurdles are not uncommon in any research, more so in funded research, but these were overcome and the project was executed successfully. This grant was open to researchers from all specialities, so to compete and succeed was a challenge. I believe the quality, novelty, and relevance of the proposal helped. Apart from this, there were a lot of paperwork and communications between me, the funding agency, and the institute, which had to be completed. Apart from this, time was also a factor because I had to recruit 400 patients within 1 year. Cooperation from my colleagues became important in these instances. So overall, there were a lot of challenges, but I also had a lot of patience, resources, and guidance from my seniors to overcome these. Regarding advice for future grant applicants, I have a few suggestions. First, it's important to identify a clinical problem that needs to be solved. Then ask an appropriate research question. Then come up with suitable methods to conduct the study. And for anybody in the earlier part of their career like me, it's important to take guidance from a mentor with a previous grant experience, somebody like J Anaesth sir. Look out for opportunities and keep applying. And remember that one may not succeed in the first attempt. Apart from this, having previous research work, including non-funded studies, pilot studies on the same topic, demonstrates your expertise and interest, and hence the proposal is more likely to succeed.
Okay, all right. Okay, thank you so much for that word of advice. So, Dr. Kamath, I want to ask you, as opposed to the conventional Evans battery of tests done to evaluate functional integrity of the autonomic nervous system, you used a bedside heart rate variability-based monitor called the ANSI-scope, like Dr. Sangeeta was mentioning. Could you tell us a little about this monitor and why you thought this was a better choice for your group of patients as compared to the conventional tests?
Yeah, the tests in the Ewing's battery for autonomic function assessments are usually carried out in the laboratory, the autonomic function test laboratory that we have. This requires a considerable amount of time. Moreover, transferring neurosurgical patients to the laboratory might itself be a challenge, especially if the patients are drowsy, have internal drains, patients are on traction, and if surgery is a kind of semi-emergency, which most of the neurosurgical patients present with.
Yes.
And some of the tests in the Ewing's battery may not be feasible, like patient on traction. And therefore, a simple point of care assessment of autonomic nervous system is desirable. And we came across a monitor that was commercially available and validated in the perioperative setting, that is Ansyscope, and used that in our study. To briefly introduce this monitor, it is similar to a routine ECG device, but has an inbuilt algorithm which captures 572 consecutive RR intervals to provide scalar imprints of sympathetic and parasympathetic systems. So based on this discordance between the two autonomic nervous system components, it provides and gives an index known as the ANS index, which ranges from 0 to 100, with higher values representing a degree of dysautonomia. And for this particular study, we used the threshold of 13.5, which was used in earlier studies as well and recommended by the manufacturer. Now, I would not call this as an ideal device, which can mimic routine standard autonomic function test assessment in the laboratory. And also, the studies using this particular device in the perioperative settings are very few. But we had selected this particular device because of the ease of testing and interpretation of the results by anesthesiologists who are not well versed in neurophysiological autonomic function testing. And it could be done in the OR itself within 5 to 10 minutes. So because of this, we chose this particular.
Okay, all right. So Dr. Sangeeta, your study looked at predictors of CAD. So did you find any positive association between factors that you studied and autonomic dysfunction in your patients?
We evaluated the baseline demographic characteristics such as age, gender, comorbid illness, neurosurgical diagnosis, socioeconomic status, and educational status for their ability to predict CAD in our patients, but none of the proposed factors could predict CAD among our neurosurgical cohort.
Okay, but did that surprise you? Because we've seen that age and diabetes, these are conditions that kind of cause autonomic dysregulation. So could you think of why you would have got a negative result in your study?
Yes, the findings were surprising to us as we expected to identify at least some predictors. There was a poor representation of elderly patients above 65 years. Most of our patients in our study, they belong to ASA grade 1 and 2 due to monospecialty nature of our hospital, because of which we had a lower prevalence of diabetes, hypertension, and ischemic heart disease. These factors were earlier shown to be associated with CAD, like you mentioned, but then due to reasons mentioned, it's possible that this was not observed in our study. Also, we had very few patients with central pathologies that can affect the autonomic nervous system, like hypothalamic lesions, insular lesions, and brainstem lesions. This also might have resulted in the findings that we noted. Apart from these, socioeconomic status and education, these were found to be associated with CAD in 2 previous studies, and hence we included them as risk factors in our study as well to examine them. But probably the small sample size might have falsely led to a statistical significance in these 2 previous studies. Lastly, Ansyscope-derived autonomic function testing is definitely not a gold standard when compared to the data we get from an autonomic lab. So these are the possible explanations for why we couldn't find any positive association with CAD.
Yeah, I kind of found that very interesting that economic background, socioeconomic background, and educational status may have something to do with autonomic dysfunction. Anyway, Dr. Kamath, you've classified your patients as early, late, and advanced CAD. Did the second and third category of patients have exaggerated hemodynamic responses? And did you look at their perioperative outcomes?
Yeah, it is likely that patients with any form or severity of autonomic dysfunction can have an exaggerated hemodynamic response at various noxious stimulus events, such as induction, intubation, etc. And also, they might have increased occurrence of major adverse cardiac events in the perioperative period. But in this current paper that we published, we focus on only the assessment and of the prevalence of cardiac autonomic dysfunction and risk factors associated with it in neurosurgical patients.
Yeah, so I actually did some reading around your article, and I found that you registered your study as a cat-pon study where you're also looking at the outcomes of these patients. Can we wait for those results?
Yeah, we are in the process of analyzing that data, and which includes hemodynamic data in the intraoperative period, and we are also looking at the perioperative major adverse cardiac events such as bradycardia, hypotension, hypertension, arrhythmias, and myocardial ischemia in the perioperative period. We will soon be sharing the findings of study with the scientific.
Okay, that will be very interesting. So, Dr. Sangeeta, this next question I want to ask you is, you said that your prevalence was 79% for CAD in your neurosurgical patients. Do you think this will have a clinical impact on the conduct of anesthesia and neurosurgical patients in patients?
Definitely, yes. The high prevalence of CAD observed in our study can be an important concern to patient care in the perioperative period. Most patients presenting for neurosurgery have an underlying deranged cerebral autoregulation, which is a key determinant of cerebral perfusion. In addition, presence of cardiac autonomic dysfunction can further compromise cerebral perfusion, especially during vulnerable phases of surgery and during perioperative blood pressure fluctuations. Hence, knowledge about the preoperative presence of cardiac autonomic dysfunction will help the neuroanesthetist to determine the ideal individual blood pressure target for these patients and successfully navigate through intraoperative BP fluctuations to ensure optimal cerebral perfusion. And all these put together can serve to minimize adverse cardiac events and improve clinical outcomes in this high-risk population.
Thank you, Dr. Sangeeta. So, Dr. Kamath, this is my last question to you. A lot of work is being done on autonomic dysfunction and its association with perioperative outcome, its role in inflammation and postoperative pain response as well. Why do you think this study is relevant or of interest to the anesthesia community?
Yeah, so when patients with autonomic dysfunction present for anesthesia or surgery, they are likely to manifest with majorly with hemodynamic changes, especially during certain stressful events such as intubation, laryngoscopy, catheterization, positioning, or extubation. And moreover, the response to pharmacological interventions to correct these hemodynamic changes may also be unpredictable. It could be exaggerated, or there could be a minimal response in these patients, which can result in major adverse event which are of importance to the patient and clinician, such as myocardial ischemia or stroke, and because these carry significant morbidity and mortality. And also, right, as you rightly mentioned, there is a relation between autonomic function and inflammation and pain. Because both of these are common during anesthesia and surgery. And therefore, understanding of the perspective of cardiac autonomic dysfunction is of importance to anesthesiologists. And this study provides some relevance to that extent for the anesthesia community.
We heard Dr. Gayatri says, and she bombards with me some difficult question to me. I can take advantage of Dr. Shri Ganesh Kamath available with us. I know he works at Niemann's Bangalore. I know him that he is one of the absolutely wonderful human being, but simultaneously is a good researcher. And I'm also aware that he has a good collaboration with international people. So before Gayatri asks me some difficult question, I will target to you, sir. So when you plan an RCT, what few tips you want to give to our listeners that you assure during planning of an RCT so that it is published in a good journal?
I think the first step would be to ask important question that is relevant and that is appropriate. And that is generally seen during our clinical practice. We find some gap, we want to find some answers, then we formulate a research question, identify what is the appropriate study design for that. Not all answers can be found through an RCT, but yes, these are some of the initial steps. And then, of course, a good literature search has to be done to find out the gaps, so not to repeat what is already done. And then we have to write a proposal, and this proposal is essential to submit it to the scientific community, scientific committee, or the ethics committee. And if you are looking for funding, then of course it will go through multiple rigorous assessments, both at a technical level and at a scientific level at the funding agency, which is generally reviewed by the experts in the field. And once that is done, the conduct of the RCT also needs to be rigorously done, which includes proper randomization, allocation concealment, blinding, and inform who is blinded. I find often that people mention single blinded, double blinded, triple blinded without explicitly informing who are blinded. And therefore, these are the steps that are very important in the initial stages of conducting RCT. And I would strongly suggest that people who conduct RCTs also publish their protocol for increasing the transparency and how the study is conducted. And that will serve as a guidebook during the conduct of RCT.
Absolutely. I think you have made my job easier, and I'm sure that all the future researchers and who are going to do various publications, the editor-in-chief will look after all the points which Dr. Shri Ganesh Kamath has mentioned, and these are the mandatory requirement of any randomized controlled trial. And the second important aspect is sometimes we assume that we have done it, but we do not write in words. And Dr. Shri Ganesh has mentioned it very clearly that it cannot be as simply say that blinding was done. It has to be explicitly mentioned in words that how the blinding was ensured during the study process. Thank you so much, Dr. Shri Ganesh, and over to Gayatri back.
Thank you, Dr. Rakesh.
Thank you so much, Dr. Rakesh, and Dr. Sangeeta and Dr. Kamath. Thank you so much for joining us at the podcast and sharing your wonderful work with us and the interesting aspects, and also giving us tips about how a good RCT should be done. Thank you so much once again.
Thank you, Dr. Gayatri. Before I conclude, I just want to congratulate Dr. Rakesh and his entire editorial team and the IJA podcast team led by Murli and you for conceiving this idea and executing it in such a wonderful manner month after month. And best wishes for your future podcast as well. Thank you.
Thank you so much.
Thanks to the podcast team. Best wishes.
Thank you. Thank you, Dr. Sangeeta.
Thank you. Thank you.
So friends, the third article we're going to discuss today is a clinical communication to the journal. Comparison of the scan-as-you-go technique with the short axis out-of-plane technique on the incidence of posterior venous wall puncture in ultrasound-guided internal jugular vein cannulation, a randomized controlled trial. And joining us to share some insights into this work is Dr. Chitra Rajeshwari T, Additional Professor, JIPMER, Pondicherry. Dr. Chitra, welcome to the podcast.
Yes, thank you.
Thank you so much for agreeing to join us in the podcast. I just want to start off with the first question. Could you summarize your study for the benefit of our listeners?
Yes, sure. So basically, we conducted a randomized control trial. We had two groups. In both the groups, the patients were cannulated using ultrasound guidance. And in group one was the SAGO technique, that is a scan-as-you-go technique. We employed in group one for IJV cannulation. In group two, we use a conventional technique, that is a short axis out-of-plane technique. So in the SAGO technique, we first pre-marked the pose of the IJV. Then using the ultrasound probe, the probe was positioned in such a way that the IJV was seen in the center of the ultrasound screen. Then the introducer needle was at an angle of 45 degrees to the skin. With the needle to probe angle of 90 degrees, we could see the tip of the needle as a dot, as a hyperechoic dot on the screen. Once the needle tip was seen, the probe was slided down by around 0.25 centimeter. Now the dot disappears because the probe is slided down. Again, we need to advance the needle by a few millimeters so that the dot again reappears. These steps are repeated until the needle tip is on the anterior vein wall. So once the needle tip is seen on the anterior vein wall, we turn the probe into long axis and then we try to see the needle. Once the probe is in long axis, we advance the needle into the vein. Now we confirm that the needle is into the vein by seeing the needle shaft and the needle tip in the vein and also by aspiration of the blood. Once the blood is aspirated, the remaining steps are the same. That is, we remove the syringe, we thread the guide wire, and then we dilate and thread the catheter. In the short axis out-of-plane method, we just go by the conventional technique. That is, we go by the indentation on the vein. So again, here the ultrasound probe is in such a way that the vein is seen in the center of the screen. Then we try to indent and see. When we are indenting, in the short axis plane, we find that the center of the vein is getting indented and the needle is advanced with a gentle negative aspiration. Once the vein is entered, we confirm that by the aspiration of the blood. But what commonly happens in the short axis out of plane technique is that the needle commonly overshoots because either the pressure exerted is more or the vein may be small. So it results in the puncture of a posterior wall in addition to the anterior vein wall.
Okay, all right. So did you said that you in the say go technique, the scan as you go technique, you turn the probe from the short axis to the long axis. So did you find it difficult in somebody who's got a short neck, or did you exclude those group of patients from your study?
Yes, we had excluded patients with short neck from the study because we need some space there for us to turn the probe into long axis and then carry on.
Yes. So I've been asking this to everyone today because I'm interested in knowing what was the basis for choosing to do this study. Was there any story or background behind this? Did you have any incidents of posterior vein wall puncture that probed you to, study this subject further?
Yes, definitely. So initially we were using the blind technique or the landmark technique, and then with the advent of ultrasound, we were using ultrasound guided technique. Definitely it reduced the complications, but in spite of using ultrasound, we did have few cases where there were incidences of hematoma, like in some of the patients, the carotid was just below the IJV. So after the unintentional posterior wall puncture, it could also enter the carotid, resulting in an arterial puncture even under ultrasound guidance. And moreover, in specific subset of populations like cardiac surgery patients, where we tend to heparinize a patient, even though the minor hematoma may settle down transiently, again with use of heparin, it may increase in size. So to circumvent all these problems, we thought of a technique which would, minimize all these complications so that we go very slowly and carefully, seeing the tip of the needle and then turning it in long axis and cannulating the vein in the long axis in order to reduce this complication of posterior venous wall puncture.
Okay, and you said the posterior venous wall puncture. I'm a little curious. So in literature, does it really have a high incidence with an ultrasound guided insertion? Is the incidence of posterior venous wall puncture high?
Yeah, there have been previous studies on the incidence of posterior venous wall puncture. With a blind technique, people found the incidence was as high as 60%. Under ultrasound guidance, they found incidence of around 20 to 25% in various studies. Okay. In our study, we had found an incidence of 21%.
Okay, all right, okay. So in your study, you chose anesthesia residents to do the procedure. So is this because you thought that the incidence of posterior venous wall puncture might be less if it's an experienced practitioner? What was the thought behind choosing the residents to do it?
Yeah, the consultants will have more experience. They will tend to go more slowly, even with the indentation technique. And moreover, us being a teaching institution, we wanted to train up the residents. So we included the residents to perform the technique after them having a minimal training. Like as per each technique, they should have at least done 10 cannulations. Then we enroll the residents into the study.
Okay. Was there any difference in time taken for the two techniques when you compared the time? Was there any difference in the time, and how much difference in time was there?
Yeah. In the SAGO technique, the time taken was statistically significantly more longer as compared to the short axis out of plane technique. In the SAGO technique, it was like 285 seconds. That is 4 minutes and 45 seconds. Whereas in the short axis out of plane technique, it was 204 seconds. That is 3 minutes and 24 seconds. So though statistically significant, clinically, it was hardly a minute longer. So that shouldn't be much of a problem for regular routine use.
Okay. Did you also collect data on the ease of cannulation with each technique? Because I see that in the SAGO technique, you keep following the tip of the needle till you then turn to the long axis. So was there any data collected on the ease of cannulation?
Ease of cannulation data we have not collected, but especially while teaching the residents, we found that initially they tend to have more of a struggle because they have to track the needle at every point of time, and then they have to turn the probe also from short axis to long axis. But once they perform few cannulations, then they are used to the technique.
So would you recommend this as a safer technique for IJV cannulation in clinical practice, even though you saw that the time taken was a little longer and maybe the technique is not as easy initially to perform? Would you recommend this as a safer technique to do?
Definitely, we would recommend this as a safer technique, but it requires a little bit of a patience and training so that we exactly track the needle at every point of time in the short axis view till the anterior vein wall and then turn into long axis and then cannulate successfully.
Thank you so much, Dr. Chitra. I think I'm just waiting for the next patient to come so that I can try your technique, and I'll call and tell you how I felt it was. And thank you so much for spending your time on a weekend with us.
Thank you so much. Thanks a lot to Professor Rakesh and all the podcast team members. Thanks a lot for having me here. Thank you.
So friends, with that, we've reached the end of this episode. I hope you had as much fun listening to it as I had recording this session. The world around us is getting warmer, but you stay cool and stay curious till we meet again. Thank you.